So I'm Chaichian. I'm one of the rheumatologists here at Stanford. I'm the current director of the Lupus Clinic here. I'm honored to speak to you, be invited by the Lupus Foundation of Northern California, who does so much good work on behalf of patients with lupus, advocacy and education. One of my areas of clinical interest and research interest is in the topic of lupus and pregnancy. And as audience members here who may know somebody with lupus or may have lupus yourself, you're well aware of sort of the clinical manifestations of lupus, and in particular, I think the issue of pregnancy and lupus is really salient for patients with lupus because, as you know, it's a disorder, it's a condition that's predominantly afflicts patients of childbearing age. So this topic, I think, is something that's sometimes underappreciated in lupus, but I'm hopefully here to help provide some further information. And one of the main goals of my talk today is that I think there's some degree of misperception of pregnancy and lupus, some anxiety that is unnecessary, that's perpetuated perhaps online or other areas. And in some cases, I've heard from patients, well, you know, I've seen other doctors and they've told me, you know, pregnancy is incompatible with lupus, or, you know, they've heard different things. And one of the sort of goals of this talk is that, yes, lupus pregnancy is a high-risk condition, but significant majority of patients with lupus will ultimately be able to have successful pregnancy outcomes. So I want that to be sort of a take-home point. We will go through a lot of the individual risks of pregnancy and lupus, but I want to sort of give you specific indications in lupus that may decrease or increase the risk, so you can have an individualized plan to go and talk with your rheumatologist, your other providers, and be more informed when that situation arises. Certainly pregnancy is not for everybody. If that's something that is not something you desire, it's still helpful though to have this information, so that's the other goal of my talk. So sort of this is the general framework for the beginning portion of my talk. I think for preconception counseling is probably arguably the most important aspect of discussing lupus and pregnancy because it sort of lays the groundwork for everything that follows. A lot of, stay on the slide. Actually, can you go back to the beginning slide?
My bad.
A lot of these topics are best addressed early on because you know, timely discussion of contraception, issues of fertility, discussing the pregnancy risks, all of those ideally happen well before conception, so you inform the patient about what the risks are. If their disease activity is too high, controlling the disease better so that if they do choose to have a pregnancy, the risks are minimal. And so I feel that this is an area that we as a rheumatology community can do a better job of, but if you don't feel as comfortable discussing with your rheumatologist, you should have a rheumatologist who feels comfortable discussing this, ideally at the very first visit if you're a woman of childbearing age, just because these topics will come up and it's best to address them early on. So the first topic in preconception counseling we'll address is contraception. And for reasons I don't need to lay out, but it's extremely important. I mean, whether or not a woman with lupus decides to have a pregnancy, it's important to know, you know, what the safe birth control options are. Also, there are certain medications women with lupus are on that are often not compatible with a viable pregnancy. So it's very important to know what birth control options for you specifically are safe, and to make sure you're not having a pregnancy when you're on a medication that's associated with birth defects. And it also helps ensure that once the patient's disease activity is low, then they can proceed with a pregnancy if that's something they desire. From a medical standpoint, there's really two main factors that are associated with the choice of contraceptive as lupus providers that we would recommend. One is how active is the patient's lupus. That sort of influences what birth control option we would steer a patient towards. And then the presence of antiphospholipid antibodies, which I'll use the APL acronym, and or antiphospholipid syndrome, or APS. We'll go into that a little bit more detail later, but that's a syndrome that can be seen in isolation, but is often more prevalent in patients with lupus, and it's associated with higher risk of clotting, higher risk of pregnancy complications, so it adds another layer of complexity to lupus pregnancy. So really for some of the higher risk lupus patients, so those who have very high disease activity or who may have these clotting proteins or have had clinical events associated with that APS syndrome, the an IUD is specifically a copper IUD would be safe even in the highest risk patients. There's not been really any association of increased flares, increased clotting, So that's an option that sort of can be widely recommended to lupus patients unless there's a specific gynecologic contraindication. The levonorgestrel-containing IUD in patients who are at lower risk of clotting, who may not have as particularly active disease, can be considered. In particular, women who have issues with sort of dysregulated menstrual bleeding, this can help lower that. So that's a sort of an added benefit. Combination oral contraceptives for a significant percentage of lupus patients are a safe option. Particularly things that you and your lupus specialist would be sort of discussing would be how active is your lupus. So particularly women with lupus who've had fairly stably inactive disease for 6 months or so, or they have low or moderate disease activity, but it's generally been predictable and sort of stable activity, and they don't have one of those clotting proteins, these would be, a combination oral contraceptive would be safe. The issue is mainly with the estrogen component with an increased risk of clotting. So in those highest risk patients, this may not be a safe option. We generally stay away from this option. For a progesterone-only contraceptive for women who may have these clotting proteins or a bit more active lupus on a case-by-case basis can be certainly considered. So these are sort of a general framework of what can be considered in the setting of lupus and contraception. Despite sort of what I'm trying to sort of show you how important this topic is, there's been some evidence within the literature and just empirically that the rheumatology community may not be doing as good of a job of counseling women with lupus on contraception as we could be. There was a study out of UCSF nearly 10 years ago now where they found that 86 out of 206 women with lupus who were at risk for unplanned pregnancy, nearly 60% received zero contraceptive counseling over the preceding year. And you may think, well, maybe it was the patients who were lower risk for complications, but even women who were on medications associated with birth defects were getting sort of the same lack of attention to this topic. So sort of to drive the point home further, 53% of patients in this study were using only barrier methods, which we know are not really adequate in terms of preventing pregnancy. Only 13% were using an IUD. So basically we need to do a better job of discussing this topic and discussing it sort of in a timely manner. So I'm just very briefly going to address two topics of the fertility and assisted reproduction techniques just because I think it's relevant to this audience as well. In general, researchers haven't found a higher a risk of reduced fertility in lupus itself. So the disease itself probably doesn't cause less fertility. There is, interestingly, at the same time, a recent study looked at women with lupus who wanted to have children. Nearly 2/3 had less children than they originally anticipated. So some things at play here. There's a dichotomy of maybe there's not reduced fertility from the disease itself, but they're not having as many children as they desire. So there's a couple reasons for this. One reason would be, if you can. So a higher rate of fetal loss in lupus pregnancies. And so we know this to be the case in lupus patients who don't have antiphospholipid syndrome, but particularly those who have antiphospholipid syndrome. So, and secondly, there are a subset of women with lupus, particularly those who've had bad kidney involvement, and you may know patients with this who've been on a medication called cyclophosphamide. It's a very sort of aggressive treatment that's extremely effective, but one of the side effects is that it can cause premature ovarian failure. So in that subpopulation of women with lupus, not necessarily the disease itself, but sort of as a consequence of the treatment, they're going to have less fertility due to premature ovarian failure. Another cause would be, several studies have shown that women with lupus tend to become pregnant a few years later than women without lupus. And so there's sort of the physiologic age-related decline in fertility that occurs, and that could account for this as well. And then lastly, there's some fears associated with pregnancy and lupus. And some of these, are related to maybe, again, they're not having as good of a discussion with their rheumatologist about what are the actual risks of pregnancy versus what are sort of things that are not truly risks. So they may not want to have children, or they delay it, and so they have less children than they would originally desire. Or maybe they feel that they would be able to have a child, but because of their lupus, they wouldn't be able to take care of them as well. So all these factors may play into why women with lupus may have less children. So assisted reproduction techniques such as ovulation induction therapy, IVF, are increasingly being considered in women with lupus. In general, for women with mildly active or inactive lupus, these are considered to be safe options. They're still being studied. For particularly women who have very active lupus or have a clotting predisposition or history of significant kidney involvement. This probably is not safe based on the current level of evidence. There's been some evidence that it may increase rates of flares, could increase clotting risk. So this should be a frank discussion with a maternal fetal medicine specialist and you if this is something you're considering. But for women with sort of mildly active lupus, this is something to certainly consider. Let's go to the next slide. So the next 10, 12 slides or so, I'm going to focus on what are the specific risks of pregnancy and lupus, sort of generally, and then specifically on a few of the outcomes, such as preterm birth, preeclampsia, because I think it's helpful to look at sort of what the evidence is. We'll start sort of a little bit older data and some of the newer data. So some of the important factors when we're talking about this topic are maternal factors, so age-related factors, influence of race and ethnicity. There are disease-specific factors, so how active is the lupus clinically and how active in terms of the blood, what are the lupus markers, how do those influence these risks, and then the specific outcomes we'll talk about, preterm birth, fetal loss, preeclampsia. So this is a study published in 2008, taking data from the nationwide inpatient sample from 2000 to 2003. A couple of things I just wanted to highlight again, just as I had alluded to earlier, as you can see in terms of the mean age of lupus pregnancies in this study, several years older than the non-lupus pregnancies. And there are some racial ethnicity differences, including a higher rate of African American lupus pregnancies than in the general population. This is not surprising. We know that the epidemiology of lupus in general affects racial minorities more than Caucasians. So you would see the same thing in patients with kidney involvement for lupus, for example. And they also looked at a number of other things. So as you can see here, there are higher rates of concurrent medical illnesses that may also complicate lupus pregnancy and put patients at higher risk for adverse outcomes. So women with lupus, on average, had higher rates of pregestational diabetes, so diabetes before the pregnancy, high blood pressure, pulmonary hypertension, which is sort of elevated pressure sort of within the arteries around the heart, kidney failure, and a predisposition for clotting. And also sort of other complications of clotting, infections, complications around the pregnancy, issues with postpartum hemorrhage, bleeding, anemia, delivery were all higher within lupus pregnancies. And this is, I thought, instructive because it compares, so the purple bars are two different cohorts. So on the darker purple bar is a lupus cohort out of Sweden, actually, that one of my colleagues had studied. And the lighter purple bar is actually the same data group. And you can see that fairly comparable rates of C-section, preeclampsia, and preterm birth through the two studies. A little bit different for preeclampsia, but in general, comparable rates. And you can see that compared to the green bars, which are the non-lupus groups in each of the cohorts, there's significantly higher rates of these complications in lupus pregnancy. So it just sort of gives you a sense that multiple studies have shown sort of similar results. Yes.
What is preeclampsia?
It's a condition in pregnancy, which I'm going to actually talk about a little bit later, that is defined sort of after 20 weeks of pregnancy associated with elevated blood pressure. It's a placental issue, but it causes high blood pressure, kidney problems, and actually is sort of not necessarily independent of some of the other risk factors, preterm birth. So it's a complication that's certainly can be seen outside of lupus pregnancy. It's not unique to lupus, and but certain high-risk pregnancies have an increased risk of that. So the PROMISE study, this is moving a little bit more recent data. This was a study that took patients over approximately a decade, was published in 2015. Multiple centers across the United States, nearly 400 patients with lupus. About half were non-Hispanic white. About a third had prior kidney disease. That being said, the actual cohort, one of the limitations of this data, but I'm still going to sort of present the data, this is sort of helpful information for patients with mildly active lupus or fairly inactive lupus at the time they go into pregnancy. So they really excluded patients who had high disease activity, those who had active kidney involvement, and those who were on higher doses of prednisone. So high dose prednisone is sort of a marker that your lupus is active. So let's take that as a caveat when we interpret the results. But in this lower risk population of lupus patients, you still find that when they did a sort of a lump aggregate summary of different adverse pregnancy outcomes, it was nearly 19% adverse pregnancy outcomes among the lupus cohort, much lower among the control group, which is designated in white. But when you look at some of the specific outcomes, such as fetal or neonatal death, in this, again, lower risk lupus group, you can see the number's pretty low, about 4%. So that should be encouraging that lupus that's well controlled during pregnancy, in this group they found 96% of patients did not have any fetal loss. Rates of preterm birth in small for gestational age infants was a little bit higher, certainly, but taking all this into account, still the vast majority of patients in this cohort did not have these pregnancy adverse outcomes.
What are the risk factors? So is that subset of patients?
So that's subset without risk factors. So that was included Caucasian patients, some of the lower risk patients within this group. I believe those who didn't have like low platelets, some other markers. So the middle, so she was pointing out that there's the general control population in white, sort of the overall cohort, and then there's a lower risk group that sort of has some less risk factors. So they still have a higher risk than the general population, but less than the overall group. So that's all helpful, but you may want to know more about, what is my individual risk? So that's sort of an overall group. What specific factors predict these outcomes? So they found that, and some of these are not surprising, but predictors of an adverse pregnancy outcome included flaring during pregnancy, having higher disease activity. Interestingly, a smaller rise in your C3 complement. So you may or may not know that the complement levels are things we track with patients with lupus in general. During pregnancy, there's actually certain changes that happen, and the complement levels typically rise during pregnancy just as a normal part of pregnancy. So if there's a smaller rise or even a drop, that's a concerning sign in general. And in this study, they found that that was predictive of an adverse pregnancy outcome. A presence of a lupus anticoagulant, which is kind of a misnomer. It actually is a pro-clotting protein. That was a very high-risk feature. Women who were on blood pressure medications, and again, those who had low platelets, these were all some of the poor prognostic signs. Within this cohort, they found that the highest risk patients were those who had this lupus anticoagulant protein, or if they were non-white or Hispanic and taking antihypertensives, they were also higher risk. Despite all that, I want to make another point here is that they found like rates of severe lupus flare that were really low, so 2.5–3%, and that's not necessarily unique to this study. While we'll talk about later in the talk, lupus can certainly flare during pregnancy, but the rates of patients that have very severe flares are thankfully pretty low. And lastly, this is just to show another. This is a composite. This is a type of study called a meta-analysis that's fairly frequent within the medical literature. It's basically a statistical technique where you sort of combine and pool data from multiple studies to sort of increase your what we call statistical power. And so certain questions the individual studies may not have enough patients to sort of answer as validly. You combine these studies, and they sometimes have limitations because you may be combining sort of apples and oranges in different studies. But basically, the point of this is that much larger group of patients, so nearly 3,400 women with lupus. They compared various maternal and fetal outcomes in pregnant women with lupus, with non-lupus pregnancies, and again found higher rates of some of these various complications. Although in this composite, for example, the rates of preeclampsia were not as dramatically increased as some of the individual studies. But again, it still highlights that lupus is considered a high-risk pregnancy. So I wanted to spend the next few slides focusing a little bit more on some of these individual adverse pregnancy outcomes in lupus. Preterm birth in general in pregnancies is often sometimes happens spontaneously. In lupus, it's actually usually medically indicated. So there's something active with the lupus or other issues where preterm birth happens. And people lupus community has looked into certain factors associated with higher risk. And most of these are, again, familiar things we've already discussed. So higher disease activity, having presence of these clotting proteins, kidney involvement, these are all, again, going to give you higher risk in general for pregnancy outcomes that are adverse and preterm birth. Also, prednisone use at conception, which we know prednisone is independently associated with preterm birth, but also it may be indirectly suggesting that those women who are on prednisone had some of these other reasons to need prednisone, so it's hard to disentangle that a little bit. Preeclampsia, which you had brought up as well, is also typically medically indicated rather than spontaneous. Typically an indication for aspirin during pregnancy and aspirin early on, before 16 weeks, is to help prevent preeclampsia. So that's something that, if there's not another indication, this would be an indication to start aspirin. And there are specific risk factors that are unique to lupus that increase the risk of preeclampsia. These include again, active or even just a remote history. So you may have had kidney involvement 5-10 years ago. They found that that still lingers on and increases the risk of preeclampsia for subsequent pregnancies. Presence of these antiphospholipid antibodies, low platelets, and really a drop in complements. Because again, in pregnancy, you really shouldn't be seeing a drop in complements. They should be plateauing or increasing. So one of my colleagues, Dr. Simard, who works here at Stanford, previously was involved heavily with projects and still is in Sweden. And one of her projects was looking at a nationwide cohort in Sweden and looking at this question of early onset preeclampsia, so a subset of preeclampsia that happens before 34 weeks. And they found that in first, subsequent, and all pregnancies, this is a statistical sort of marker, but the risk ratio is higher in lupus pregnancies than in non-lupus pregnancies. To make more sense of it, though, the actual absolute numbers were still low, so maybe like 4% of lupus pregnancies had early onset preeclampsia versus maybe 0.5% in the general population. So it's still a significant risk, but it's by no means meant to represent that the most patients with lupus will develop this. One of the challenges that if you have lupus or know somebody who's had lupus and is undergoing pregnancy and they develop worsening blood pressure or they develop kidney problems during pregnancy, disentangling, is this preeclampsia, is this their lupus kidney involvement? They may not have had kidney involvement to begin with historically, but that's one of the questions that we struggle with, that maternal fetal medicine specialists and nephrologists suffer with as well. And it's an area that we need more research in, is how do we differentiate preeclampsia from lupus nephritis? I'm not here to give the definitive answer today because it's still something that we struggle with, but one point is that it's just extremely difficult. Part of the difficulty is that kidney biopsies, for legitimate reasons, are not routinely done in pregnancy. So that would be sort of the definitive way to tell, is your lupus active or is it preeclampsia? But some of the take-home points are that you can have both. So you can have preeclampsia and certainly have active kidney involvement. They also masquerade as one another. They both present with increased protein in the urine, worsening kidney function, elevations in blood pressure, and varying degrees of low platelets. Some of the things that we as clinicians help guide us to say maybe it's more likely to be lupus nephritis rather than preeclampsia would be, what are the lupus markers doing? So if the anti-double-stranded DNA was low early on in the pregnancy and then all of a sudden it's shooting up, that may be a clue that it's lupus kidney involvement. If the complements, again, unlike normal pregnancy, are not sort of increasing and they're dropping, that may be a sign. Also, preeclampsia typically gives you protein in the urine but doesn't give you red blood cells. When your doctor's doing a urine analysis, if there's a lot of red cells or red cell casts, these are signs that it may be more likely to be lupus nephritis. And also, one thing that is helpful is if it's caught or the symptoms present, say at 15 weeks or something, before 20 weeks, by definition, it can't be preeclampsia. What gets murky is when it's after 20 weeks, which one's going on. And all this has implications for, it's not just sort of a theoretical issue, it's practically speaking, we treat these things so differently. So preeclampsia, the ultimate treatment is delivery of the baby. Lupus nephritis or lupus kidney involvement, like any other active lupus manifestation, the treatment is increased immunosuppression. One of the areas that our group here at Stanford that I collaborate with other researchers are interested in is the sort of interplay of race and ethnicity on lupus and other autoimmune diseases. Several cohorts, including some of the studies that I've already presented, have shown that African American women and Hispanic women in particular bear sort of the disproportionate burden of bad pregnancy outcomes in lupus. So preterm birth, preeclampsia, a lot of these rates that we've sort of shown are even higher among that subset of lupus patients. This is not surprising. We know, again, for example, lupus kidney involvement, patients who are African American do generally worse or may respond less to immunosuppression. People are trying to tease out how much of this is socioeconomic status, other factors, or is it due to race and ethnicity, but I think it's still an evolving question and area that we need more research in. So, again, significant majority of women with lupus, you can manage the risks, and successful pregnancy outcomes are very possible. I want to still alert you to that there are certain scenarios. Some of these, thankfully, are very reversible. Some of these are more longer standing that constitute such a high risk for pregnancy and lupus in terms of adverse outcomes that it sort of warrants a frank discussion with your rheumatologist, your maternal fetal medicine specialist, if you or somebody you know who have these risk factors. Just the challenges it poses for a successful pregnancy outcome are so great that at least deferring pregnancy until these risk factors are sort of modified and are less, or in some cases if it's something that's not getting better, for example, if there's severe lung disease or really advanced pulmonary hypertension, those things are often hard to treat. The risks may outweigh the benefits of a pregnancy. Thankfully, these are not representative of the vast majority of lupus patients. So for this first part of the talk, the take-home message is that despite these risks that are very real that I've discussed, and lupus is and will be considered a high-risk pregnancy condition, the overall rates of complications have dramatically improved over the years. So, lower rates of pregnancy loss from nearly 45% in the 60s to 17%, which is now even 15 years ago. There's fewer preterm births over time. So the bottom line is that lupus is a high-risk concern, but viable pregnancies are very, very possible, and the risk just needs to be individualized between you and your providers. So in women who do choose to have a pregnancy and have successfully conceived, they're following closely with their rheumatologist, their other providers. The question then becomes, what happens to my lupus during pregnancy? Is it going to be more active? Is it less active? How does it affect me? Before I get into that part of the talk, just very briefly I want to discuss that, and this is important, there are a lot of changes just normally in pregnancy that can sometimes mimic active lupus. There are some subtle differences, and we'll try to go through those. So normal pregnancy changes, some facial flushing, redness along the palms, that can be differentiated from a lupus rash. So if it's some flush along the cheeks, that the butterfly rash of lupus, that may be very difficult. Typically those are more raised, inflammatory, may have some surface changes. The distribution may be helpful, but that's an area that can be a little bit confusing. It's normal to have aches and pains, joint pain, and it's extremely common for pregnancies in general. Lupus arthritis, typically some of the telltale signs would be objective swelling of the joints that are unique to the joints, not just overall swelling, and prolonged stiffness in the morning. That may sort of give away that it may be more likely to be lupus. Fatigue is just difficult to tease out because it's common with lupus, it's common during pregnancy. If you really have a lot of swelling during a pregnancy, that's an area to be more vigilant. Your doctor should check your kidney function, check the urine for protein, because sort of you may be going beyond what's a normal, acceptable amount of swelling in pregnancy. And with some of the progesterone changes during pregnancy, you can get some hyperventilation in pregnancy, and that can cause some shortness of breath. That's common in pregnancy, but to really have chest pain with deep breaths or fluid around the lining of your lungs, which is also called pleurisy or pleuritis, that would be unique to lupus, not just the pregnancy. The bottom half of this table is meant to show that there are a number of, and we've alluded to the complement issue, that normally the complements rise in pregnancy, but there are also other changes that are just happen in pregnancy, and so knowing that this happens can be helpful and avoid unnecessary alarm. So if there's a mild anemia and not much else is going on, the patient's feeling well, that's probably just the anemia of pregnancy. Platelets drop a little bit, that's normal in pregnancy. What's concerning is if you have really low platelets where they were always normal, they've dramatically dropped, that can be a sign of a lupus flare. Or, for example, protein in the urine, very common with pregnancy to have low-grade proteinuria. What we get concerned about is if it's more than 0.3 or really 0.5 or higher grams of protein, that would be suggestive possibly of lupus kidney involvement. So most authors, most people who've looked into this question have found that lupus disease activity probably does increase during pregnancy compared to the pre-pregnancy state. How frequent this is a matter of debate depending on what study you look at. So that's why 25 to 65% seems like a wide range. It's because different authors have used different criteria to assess what a flare is. They may have sicker or less sick lupus patients, so you get different numbers. But generally, you can say that there's a sizable percentage of patients with lupus will flare during lupus pregnancies. And some of the key factors that are important to know are consistently come up in terms of predictors of a flare would be how active was the lupus at the time of conception. So again, this brings home the point of how critical it is to have preconception counseling, making sure your lupus has been as quiet, as inactive as it can be for as long as it can be before pregnancy. Because if it's not, we know that it leads to worse outcomes. Again, one of the things that's unique about kidney involvement is lupus. It's not just active at pregnancy, it's just a history of it, unfortunately, having a history of kidney involvement. Fortunately, a lot of patients with lupus do not have that. And then hydroxychloroquine, which is sort of the foundational medication for lupus, it's been shown that stopping hydroxychloroquine during pregnancy can predict flares as well.
So is there any particular trimester where the risk is highest, or it's pretty evenly
For
spread out?
the flares?
For flares, yeah.
In the studies that I've looked at, it was variable. There's not a particular consensus at this point. It can happen at any trimester. And postpartum, those weeks after pregnancy, often there's a little bit more risk for activity. Not in everybody, but that's an area where we sort of watch patients a little bit closer. Yeah.
Do you recommend discontinuation of hydrochloroquine before pregnancy?
Continuation or discontinuation?
Discontinuation.
I would not recommend discontinuation of it.
Okay.
So
it's safe.
It's safe. Pregnancy. It's very safe for pregnancy. Now I'm going to go into a little bit more detail on some of the specific safety data on the different medications, but hydroxychloroquine is very safe during pregnancy. Some providers, if somebody's not on it and it's in the middle of pregnancy, may not start it just because it's adding a new medication. My personal preference is I would still start it during pregnancy just because we've had a lot of cumulative data that it's safe. So the most flares during lupus, even if it is fairly common, tend to be mild to moderate. May be able to be managed with low doses of prednisone and sort of pulling it away rather than throughout the pregnancy. This was a study out of Harvard, out of Brigham and Women's Hospital, published in 2015, but basically looked at what are the different organ systems, because lupus, as you know, is very heterogeneous. Not everybody flares in the same way. What were, in their cohort of patients, the most common flares? One reassuring thing just to look off right off of the bat is that the actual percentage of these different flares is low. So there was 12% even of the most frequent flare, which was blood count issues, so maybe low platelets or low white count. Kidney involvement about 7%. Skin disease, arthritis were the next most common. Serositis refers to sort of inflammation along the lining of the heart or the lung. And there were patients who had more than one organ involved, but again, thankfully that was low at about 4% of patients. This is from the same study, and again, sort of reinforcing one of the points that I've been making is that, so they looked at percentage of patients who had one of those organ systems active during their pregnancy that I just went over, and how many of those had the same organ system involved the 6 months prior to conception. And so for the blood count, it's maybe 70%, 60, 40, 20, 40. So a sizable percentage of the patients had the exact same organs involved the 6 months prior. So it sort of, again, reinforces that as much as you can control lupus activity before pregnancy, you're setting yourself up for much better outcomes during the pregnancy. So kidney disease we've kind of already been talking about because it is a recurring theme in terms of assessing risk in lupus pregnancy, but 30% of lupus pregnancies will, at some point, will be impacted by lupus nephritis, the other word for lupus kidney involvement. And they've found that the history of lupus kidney involvement or active lupus kidney involvement during conception is associated with a higher risk of flare during or after pregnancy, and also preterm delivery, and just in general, worse outcomes. Interestingly, and these outcomes are maternal outcomes, whether having kidney involvement leads to worse fetal outcomes, so growth restriction or small for gestational age babies, that's still an area that the lupus community is sort of struggling with. There's been a couple studies that have been published. One showed that yes, it may increase the risk of fetal outcomes, and another study said it doesn't impact those. Having a history of lupus kidney involvement. So the management of kidney disease in pregnancy is sort of dictated by what's safe in pregnancy in terms of medications. We'll talk about those a little bit later, but and you sort of stratify patients with kidney involvement based on their risk. So the lowest risk group would be on the left here. So these are patients who have a history of kidney involvement, but during this pregnancy, the current pregnancy, they don't have any active involvement. So their urine is not showing protein, their kidney function is normal, everything looks good. These recommendations are from 2012 from the American College of Rheumatology, sort of came out with a recommendation statement on lupus nephritis. They recommended no specific treatment in this scenario. I would argue that maybe the caveat is that no specific treatment beyond hydroxychloroquine. Again, we know in general it's beneficial for pregnancy. Patients with lupus kidney involvement inarguably are probably at a higher risk group, so probably they should already be on hydroxychloroquine. Then there's a sort of a middle group where, yes, they have some protein. It seems likely that it's from the lupus. It may not be preeclampsia, but things are going pretty well. It's not a particularly high-risk pregnancy. Everything looks like it's going to be a successful outcome. Probably just continuing hydroxychloroquine, monitoring really closely with your rheumatologist, your kidney specialist throughout the pregnancy is probably sufficient. There are a subset of patients that we do see from time to time who have more active lupus during pregnancy, the protein's rising above a gram, or the kidney function is a little bit abnormal. That's where steroids come into play, and they can often be very effective and quickly effective during pregnancy. And then azathioprine, which many of you may be familiar with, is a medication we often use outside of pregnancy setting as well. It has very good safety data in pregnancy. For that subset of lupus kidney patients, that sort of becomes sort of one of the key medications. There are rare scenarios where they may just have extremely active kidney involvement, and considering delivery after 28 weeks for a viable fetus may need to be considered. Yeah.
Are there other medications for the patients with active lupus that a physician might consider other than AZAPs, like tacrolimus?
Yeah. So that's a good point. Even for kidney involvement, tacrolimus or cyclosporin, specifically for that indication, are probably good medications to consider because we use them a lot outside of pregnancy, and they have good. Thankfully, they've been used in transplant for many years, so a lot of the long-term pregnancy data is from that literature, and it's been shown to be safe in pregnancy. So,
is there like a medication that's safer than the others in terms of the three that you just mentioned?
we'll talk about it a little bit later. They haven't really been directly compared. I'll go through some of the safety data and the risks for each of them a little later. So antiphospholipid antibodies, again, we've been talking about it, but just some additional information on this. Certainly you can have antiphospholipid antibody syndrome and not have lupus, but if you do have an autoimmune condition, the most likely reason that you'll have a most likely concurrent autoimmune condition with antiphospholipid syndrome is lupus. And the definition of antiphospholipid syndrome, or APS, is having a clot, and it doesn't have to be a DVT or a blood clot in the lung. It can be an artery clot or a small vessel clot. So you may not have that. You have a specific pregnancy complication. It's oftentimes a miscarriage, but it can also be severe preeclampsia. Plus having these antibodies, these pro-clotting antibodies, not just once, but persistently, and that's sort of defined as having it on 2 separate occasions, at least 12 weeks apart. So that sort of defines this syndrome of APS. And one take-home point is that there are a lot of patients that I see, others see, that we have one of these antibodies, or maybe have 2 of these antibodies, but they've never, thankfully, developed a miscarriage or a pregnancy abnormality. They've never developed a clot. So that's like the larger pool of patients is those who have these antibodies who are not developing these complications. But even within having these clotting proteins, they're not all created equal. So there are certain ones that are higher risk, particularly for pregnancy, having these at sort of moderate or high levels. So having it at a borderline level is fairly reassuring. Having it at a higher level is more concerning. Having more than one of these, and then having that lupus anticoagulant in particular seems to be the one that, in terms of fetal loss or other adverse pregnancy outcomes, probably is the highest risk, at least based on the literature at this time. And so some of the higher pregnancy risks associated with patients who have these are high risk of clotting events for the mother, fetal loss, growth restriction, preeclampsia, preterm birth. Interestingly, a group published a paper last year that looked at, so is it worth checking these antibodies multiple times during pregnancy? So if they're one level in the first trimester, if we recheck them in the second and third trimester and they fluctuate, does that fluctuation have any relevance in terms of predicting which patients are more or less likely to have bad pregnancy outcomes? And they found that it doesn't actually predict. So you're going to be having, as part of your routine screening early on in the pregnancy, you're going to check these antibodies, some other antibodies, what are your blood counts doing, what is the urine protein looking like? But once you've checked in the beginning, probably not relevant to recheck it. And again, some of this is expert-based, so some of this is based on evidence. What's probably less based on evidence, but is sort of very widespread practice just because it makes sense and we're concerned about women who have these proteins becoming pregnant, is that if you have these proteins in the blood, so these antiphospholipid antibodies, but you've not had any clinical events, you've not had a clot, you've not had any miscarriage or adverse pregnancy outcome, it's probably still a good idea to be on a low-dose aspirin. I don't know, there's not really much evidence behind this, but sort of everybody feels that that's probably the safer option to consider at this time. There's sort of a middle group where they've thankfully not had like a DVT or a blood clot in the lung, but they have had recurrent pregnancy losses and have these antibodies. In that setting, if they are they conceived, they're having a pregnancy, you do the low-dose aspirin, but you also give prophylactic or these lower doses of heparin, and typically it's just going to be low molecular weight heparin because of ease of use. The highest risk group would be those who had systemic clot, so a DVT or a stroke or some other complication, and you're going to treat with therapeutic or very higher dose heparin during the pregnancy, 6 weeks after the pregnancy, and then bridge with Coumadin afterwards, because as you know, Coumadin is completely not safe during the pregnancy. So ultrasound monitoring for the fetus during pregnancy, some of it's standard between 11 and 14 weeks. There's sort of routine monitoring also between 20 and 24 weeks. In women who have fetus that there's concern for early intrauterine growth restriction, there's additional ultrasound monitoring also for late IUGR. And then we're going to be talking next about neonatal lupus. And so there's an additional screening in women with neonatal lupus later on during the pregnancy. So neonatal lupus, there's a subset of women with lupus who have SSA and SSB antibodies. And most women with lupus don't have these, but those who do, these cross the placenta. Thankfully, most of the manifestations, such as this baby here, has a typical sort of like a butterfly red rash on his cheeks. Most of these are actually just dependent on the mother's antibodies, these antibodies crossing the placenta, and then these antibodies tend to disappear about 6-8 weeks after birth. So while it can be traumatic for the mother, the baby, everybody involved, thankfully a lot of these manifestations go away within that time frame, and then it's resolved. Beyond the rash, again, some of the reversible ones are elevations in the baby's liver counts, or their blood counts can be a little bit abnormal. However, there's a small percentage, so of women who even have these antibodies, about 3% can have a complication called complete heart block. So that's sort of the most worrisome concern that may not be reversible. So 2% of exposed pregnancies, again, not 2% of lupus pregnancies, 2% of women who have these antibodies may have this more severe form of neonatal lupus. It typically occurs between 16 and 26 weeks, so that's where a lot of the, if a mother during the initial sort of screening of their pregnancy has these antibodies, you're going to be getting an additional round of ultrasound to look for any early signs of that this a conduction problem in the baby. Usually, thankfully, you can see sort of some early signs, so in that point you may be able to treat earlier and help prevent from the more severe conduction block. While the risk is 2% of exposed pregnancies, if you've had a baby who's had this, the risk for subsequent pregnancies unfortunately goes up a little higher, 16 to 20%. And the mortality rate in the babies is 20% who have complete heart block.
Can you test for SSA and SSB antibodies?
Yeah, it's routinely, it's very easy to do. It's not influenced by anything, so it's a very reliable test. And those babies who do survive up to 70% will require a pacemaker, so it's one of the more serious complications of lupus pregnancy.
So do they require a pacemaker for a certain period of time or for the rest of their lives?
I think it tends to be long-term, because this is not something generally, once it's reached complete heart block, so second-degree heart block and first-degree heart block are still felt to be reversible with some of the medications on the next slide we'll discuss. When it's third-degree heart block, it's sort of long-term complication. So a Doppler echo, so using Doppler ultrasound basically is the preferred screening tool. Again, it's done weekly between 16 to 26 weeks when you're concerned about a baby that may have this complication, and then every 2 weeks during the pregnancy afterwards. Researchers within the lupus community are still actively looking into treatment approaches, and there's actually studies ongoing right now looking at hydroxychloroquine again. What is the role comparing women who've been on it well in advance of the pregnancy versus later, who have babies who develop complete heart block, what are their rates? So we'll have more information hopefully in the next couple of years in terms of the role of hydroxychloroquine. Currently, for all the reasons we've already discussed, how helpful it can be during pregnancy, hopefully women in general who become pregnant are already on it. Other treatments that are often still used are IVIG, or it's also called intravenous immunoglobulin. There's the two larger sort of randomized trials where they sort of blind the doctors performing the study and the patients in terms of what the treatment is. Those unfortunately didn't show a benefit for neonatal lupus or complete heart block, but some other studies have shown it, so it's still typically used. And then certain type of steroids called fluorinated steroids, dexamethasone would be an example, but not prednisone, are often used when there's earlier heart block because it may help sort of avert the full heart block. Unfortunately, if it's complete heart block at this point, it's not something that can be reversed. And the steroids have to be used cautiously because they can also cause growth restriction, preterm birth, so it has to be balanced weighing the benefits and the risks. So one of the other, I think, important topics to discuss, I think, is what are safe medication use during pregnancy, because it's clearly not the same reservoir of medications that you're going to be using outside of the pregnancy setting. That being said, when there is a medication that you're choosing that is safe, the same treatment principles are going to apply. I mean, you need to get the disease under control. You treat based on how severe the flare is and what organs involved. So treating a skin flare versus an arthritis flare versus a kidney flare are all different organs and all have different implications on the mother and the baby's health. So you sort of may use milder medications for some flares, more severe or more significant medications for others. And you need to balance out the risks of undertreating. You know, there's definitely risks of undertreating lupus during pregnancy versus the risks of the medications themselves. So before we go into each of the medications in general, this is just a list of the key medications that we use to treat lupus in pregnancy. You can see that hydroxychloroquine, again, is sort of the foundational medication. Steroids, azathioprine, cyclosporin, tacrolimus, IVIG, and then plasmapheresis, which is rarely used but is also felt to be safe. So many of you are very familiar with hydroxychloroquine. It's actually an anti-malaria drug originally, but it's used in lupus. It's by far the most commonly used anti-malarial drug in lupus. There's chloroquine, there's quinaprine, others, but it also has the strongest safety data in pregnancy. So going back several decades, multiple studies have looked at its safety. Part of the reason for that is that it has a lower concentration in the placenta than chloroquine. But when investigators have looked in the safety data, they found reassuringly no increased risks of fetal death, congenital malformations, issues with the eye or the nervous system in the baby, or preterm birth. And so it's sort of, maybe in the early 90s and before, there was some trepidation of using this in pregnancy. And if you look back at studies from that time, or just in general, women with lupus during pregnancy were not being placed on hydroxychloroquine, or maybe it was being held beforehand. There's been a sea change at least 20 years, but especially in the last 10, 15 years. So it's generally always continued. And they've also found that if you continue it compared to if you just stop it before or during pregnancy, there's lower rates of disease activity. And we've shown that how active your lupus is plays a role in some of these complications during pregnancy. They've also shown lower rates of prematurity, growth restriction, and other benefits in multiple other studies. So steroids are sort of often a necessary medication in pregnancy. We all know that everybody would, as providers, as patients, would love to avoid using steroids as much as possible because they have a lot of undesirable side effects, but they work really effectively, they work quickly, and sometimes when there's a significant flare, when you need to treat it quickly, this is sort of unavoidable to use. And in general, as long as you use doses that are lower for the shortest amount of time, it generally has an acceptable safety profile. That being said, as you can see, there's maternal risks. Infectious risk is not unique to prednisone. It's consistent across any immunosuppressive, with the exception of hydroxychloroquine. But there are also some fetal risks. A lot of these risks, thankfully, are dose dependent and how long you're on it. So a woman who's on 20 milligrams or 25 milligrams of prednisone for most of the pregnancy, these risks are going to be magnified compared to just being on 5 to 10 to control the mild lupus arthritis flares. So I want to highlight for the fetal risks, there's a couple earlier studies that showed maybe there's an increased risk of cleft lip in babies exposed to prednisone during the first trimester. There's been a number of studies since then that have not sort of validated those findings. So it's just something to be aware of. But in general, since it's not really been a consistent finding in the studies, and lower doses generally are safe, as long as you're aware of how you're using the prednisone during pregnancy, it's generally considered to be a safe option. So azathioprine, a lot of the data actually precedes its use of lupus. So in transplant population, women with transplant who become pregnant, there's a lot of safety data. The keys to making sure it's safe in pregnancy are using doses that are appropriate. So 2 milligrams per kilogram your doctor would calculate, making sure it's less than that. A lot of one of the key side effects of this medication is bone marrow suppression, so bringing down your counts. As long as you keep it at that dose, you reduce the dose if you see any signs that the white blood cell count of the mother is low in the third trimester. Those can help make it safe. You also want to check what's called a TPMT level before you check it. This is something that your doctor, your rheumatologist would typically check. It's an enzyme that, if it's abnormal, you may metabolize the medication differently, and it could sort of build up unusually higher than somebody who who has a normal level. There's really not been, over all this time, any major fetal risks. There's a question of maybe a slightly increased risk of what's called an atrial septal defect or ventricular septal defect in the baby's heart. And areas that still need to be looked into further. So there's occasional cases of low counts in the infant. Again, using lower doses, these risks can be mitigated. There was one study out of the University of Michigan in 2013 that was published that found that in babies exposed to mothers who were using azathioprine during their lupus pregnancy, there was a higher risk of use of special educational services later in life for the baby. This was a fairly small study. There's been no other studies yet to follow up on this, so I think it's something that we'll know more about in the next 5 to 10 years, but I think overall it's still considered by rheumatologists, by OB doctors I've talked to, and others to be a safe medication during pregnancy. One of the questions raised from the audience was, what about tacrolimus or cyclosporin? These fall into a class of medications we just call calcineurin inhibitors. They're very similar medications. Sometimes the monitoring is a little bit cumbersome because you have to check these levels, and so it's a little bit more intensive in terms of the monitoring than azathioprine. But for some of the same subset of patients with lupus who may have active disease during pregnancy, particularly kidney involvement, adding one of these, for example, to azathioprine or in place of it may be effective to control things. And there's been really no significant bad signals in terms of safety data during pregnancy. So as long as they're using a low dose and monitoring closely, these are probably considered very acceptable options. And there's not a lot of scenarios in lupus that you'd use one of these medications, but I just bring it up. IVIG, plasma exchange, are actually more used in sort of severe cases of antiphospholipid syndrome in which the usual medications haven't worked. But in lupus, we don't tend to use these medications too much. There's not a lot of data in the literature in general, even beyond lupus, in terms of safety, but everything that's been published suggests these are both safe to use in pregnancy. So the one sort of point is that for IVIG, generally your physician would want to avoid using it after 32 weeks of gestation, just because they found that at that point it builds up, it transfers through the placenta a little bit more. So that's all the medications that are safe to use in pregnancy. Then there's a list of medications which are generally completely sort of out of bounds, should not be used during pregnancy. And the reason is they just have very high rates of birth defects that have been consistently associated over time. So cyclophosphamide, methotrexate, mycophenolate, leflunomide. So these should all be avoided. Methotrexate should be held or switched to something safer at least 3 months before pregnancy. Mycophenolate, they say at least 6 weeks before pregnancy, but I'd already probably 3 months to transition. And there's been studies that have shown that women who have kidney involvement who transition from mycophenolate to azathioprine in advance of their pregnancy and can have very successful outcomes. And then leflunomide is a medication that lingers in the body for a long time. The levels can stay for months or even a couple years. So if somebody was on that and wanted to become pregnant, you'd have to do a formal washout procedure with a medication that gets rid of the medication. In the last, I would say, 5-10 years, more patients with lupus are being treated with belimumab. Belimumab, actually, I would say 6 years because it was approved in 2011. Rituximab is sometimes used for severe cases of lupus. We just don't have enough data in pregnancy for these medications, so it's sort of it's not an absolute contraindication, but most people would still avoid this in pregnancy. Thankfully, what's been reported, and there's actually a registry right now for belimumab in pregnancy and finding out what the outcomes are, there's been no increased rate of fetal anomalies with these medications, but we just don't know enough. And rituximab can specifically deplete, in some cases, the baby's B cells. So generally avoiding these medications, and in the case of rituximab, making sure the mother's off of it for about a year before conceiving would probably be the best solution. And just briefly, these are medications that are not unique to lupus, but just as in non-lupus pregnancies, oftentimes you'll need to control blood pressure, or maybe there's some mild arthritis and you need to use an anti-inflammatory. This is sort of goes through what are some of the safe and not safe options. So controlling blood pressure in pregnancy, some of the safe options would be nifedipine, methyl-dopa, and a medication called hydralazine. I personally would argue, and most lupus specialists would say, that hydralazine specifically would probably not be the choice for a lupus patient, because unless there's nothing else available, because it's been associated with cases of drug-induced lupus. It's actually a fairly common cause of drug-induced lupus. That's not the same thing as lupus itself. It presents differently, but when there are other options, you would certainly want to pick something else. Beta blockers are a common class of medication to treat blood pressure in pregnancy. They should be used kind of cautiously because they have some risks. And then ACE inhibitors are a class of blood pressure medication. The common one is lisinopril. ARBs are a class. Losartan is another one. Those should have known risks in pregnancy, should be avoided. For mild lupus arthritis, particularly given the concern of that some women just don't want to be on prednisone, using ibuprofen generally is fine in the first or second trimester. We need more information. There's a recent study that showed maybe there was possible birth defects with use of this in the first trimester, maybe some impaired kidney function in the baby with use after 20 weeks. In general, that's still one study against many years of use. We do know that after 32 weeks, you should not be prescribed ibuprofen, Aleve, or naproxen, any of these medications, just because these, along with actually aspirin at that point in time, but particularly these medications can cause premature closure of the important blood vessel in the baby. And then celecoxib is a subset of these NSAIDs or nonsteroidals. There's just not enough good safety data in pregnancy, so generally avoid those in general. And then last, yeah.
I have a question. Are there any vitamins you should or shouldn't be taking as these patients during pregnancy, or is it the same as?
It's generally the same. There's not any specific different subset of vitamins that should be. Women with lupus are often more vitamin D deficient, so that would still hold true during the pregnancy if that's the case, to make sure they're adequately depleted. Just a brief tangent in terms of supplements, there's not really any specific lupus diet or things to sort of avoid, except for probably echinacea and alfalfa sprouts. Of all the things out there, probably those two things, specifically alfalfa sprouts, has a substance within it that may increase inflammation. And so those, but in terms of vitamins, it's a general sort of multivitamin, folic acid, the usual things that are important during pregnancy.
So nothing else in terms of like a specific type of diet?
I mean, patients with lupus have higher risks of cardiovascular risk, inflammation related to lupus, so an anti-inflammatory diet, cardioprotective diet, diets that are high in, lean meats, fruits, vegetables, avoid refined carbohydrates like pasta and rice, or minimizing those. All those things are going to be beneficial. Is there high levels of evidence or data to suggest that? They're not as well studied. So there's not really a specific lupus diet, but sort of those types of diets would probably be the best. But in terms of medications during breastfeeding, and again, this is an individual choice. Not every mother desires to breastfeed their infant, but if they do, you'll see that some of the same medications are again, the medications that are safe, the medications that are considered not safe are very similar compared to during pregnancy. So again, hydroxychloroquine, azathioprine, cyclosporin, tacrolimus, and prednisone. Higher doses, for most women who are on lower doses of prednisone, there's no concern with breastfeeding. At higher doses, very high doses, it may temporarily interrupt the milk supply. There may need to be some spacing between the dose of it and breastfeeding. And more so just because of an absence of safety data or just limited data, some of the same medications that were contraindicated in pregnancy should not be used during breastfeeding. The one limitation is that, again, I personally have not had patients who have been on rituximab with belimumab. I've tried to switch them to another medication if they're breastfeeding just because there's not a lot of information. But it's argued that these two medications are very large protein molecules, so just based on the structure of the medication, they're unlikely to actually be excreted into the breast milk that much. And also the baby's GI tract probably destroys a lot of the medication, so the actual likelihood that they'd have some of the medication affecting them is probably pretty low. So inadvertently, a mother who's breastfeeding was still taking this, rituximab and belimumab probably are okay. But it should still be something to discuss with your rheumatologist just because we don't have that much data. And this slide is just more of a summary, again, going over some of the key concepts we've talked about. So in terms of counseling patients regarding pregnancy and lupus, again, first of all, you want to make sure the patient doesn't have one of those very high-risk scenarios, so very severe kidney involvement or lung involvement or very high disease activity within the 6 months prior to conception, because those may be scenarios to delay or avoid pregnancy. Most women, thankfully, won't fall into that category. If their disease activity is controlled, you can proceed with pregnancy planning if disease activity has been stable for at least 6 months. And then we get into risk stratifying these patients. So we talked about some of the main ways we stratify patients with lupus during pregnancy is these antibodies. So do they have these antiphospholipid antibodies? Do they have the SSA and SSB antibodies, which again are very easy to measure? And if they do, they're sort of at a higher risk than the general lupus population. If they don't, you're moving into a lower risk. And you really want to involve all the providers closely up front. So as rheumatologists, we work closely with maternal fetal medicine specialists. And at Stanford, we have an excellent group here. This should all be done early on. And then you're also counseling patients really early on about what medications are safe. And if you're not on a safe medication, let's transition you to something that is compatible with pregnancy so that everything can be done sort of safely. I wanted to leave on another positive note is that there's actually over 20 active studies that are currently being funded by the NIH looking into issues relevant to lupus and pregnancy or in this general area. There's numerous foundations, nonprofit groups that are funding additional research in this area. And here at Stanford, I'm working with several others here. Recently started up a reproductive rheumatology research working group. We're interested in some of these questions of finding out more about lupus, pregnancy, and actually other autoimmune disease in pregnancy. With Dr. Drusen from Maternal Fetal Medicine, within the last year, I've set up a conference series that we discuss challenging cases of autoimmune pregnancy. So we're sort of collaborating from that standpoint to better understand some of the higher risk pregnancies. And we're working on additional projects as well, so it's an area of ongoing interest. So thank everybody for inviting me to speak with you.